Uh, Here we can see the nerves, arteries, veins, bones and joints, ligaments. But we will not discuss all these in details because we are having only 1 hour. We will be talking about the pulley system and muscles and tendon. Now, coming to the pulley system, there are three types of pulleys in hand. Uh, One, the wrist pulley, where the flexor retinacular and extensor retinacular. We are not going to discuss about the extensor retinacular because it is related with the extensor tendon injury of hand. But of course, the flexor retinacular, which is the roof of carpal tunnel, and through that, the 9 tendons are passing. That four flexor digitorum superficialis, four flexor digitorum profundus, and one flexor pollicis longus. And the most important structure, the median nerve, also passes through this flexor retinacular. Now, if you talk about the finger pulleys, there are two types of finger pulleys: annular pulleys and cruciate pulleys. And of course, there are pulleys in the thumb also, two annular pulleys and one oblique pulleys. Although we are not going to discuss about these thumb pulleys. Now coming to the wrist pulley, uh, here as I talked that this is the flexor retinacular. If you can see here the cursor, this is the flexor retinacular. Through that, the 9 tendons are passing, four flexor digitorum superficialis and four flexor digitorum profundus and flexor pollicis longus along with the median nerve. Now coming to the annular pulleys, if you can see here, there are 5 annular pulleys and 3 cruciate pulleys. So these 5 annular pulleys, if you can memorize it, A1 is present at MCP joint, A2 is present at the proximal phalanx, then A3 is present at the PIP joint, A4 is at middle phalanx, A5 is at DIP joint. Now, in between A2 to A3, there is a C1, that is cruciate pulleys, and A3 to A4, C2 is there, and then A4 to A5, C3 is there. Now, these pulleys are very important in context of tendon injury. These pulleys gives the stability to the tendon, the flexor digitorum superficialis and profundus. It also gives the direction of the movement. If there is, by any reason, if these pulleys are affected, then that can cause to the bowstringing of the tendon. Now here you can see that if there is any injury to the pulley system, it can lead to bowstringing, and in the late stage, it can cause the finger flexion contracture. In this picture, you can say that there is a bowstringing of this tendon, and here down you can see the another picture. The A3 pulley is affected, and because of that, the tendon has pulled up and causing the bowstringing, and in late stage it will cause the flexion contracture at PIP joint. Now coming to the tendon healing, it's very important to understand the tendon healing because most of the protocols are based on the healing stage of the tendon. So if you have the sound knowledge of this tendon healing, if you have the concept of this tendon healing, probably it will be easy for you to prepare your own protocol based on the standard protocol which is there in which we all are following throughout the world. Now there are 4 stages: hemorrhagic phase, which is for few hours, then inflammatory stage in between 24 to 48 hours, and the most important is proliferative stage, which is for few days to few weeks, when the collagen synthesis is on peak. Now, let me tell you in this way that when there is any injury in our body, the fibroblast cells runs towards that injured site, and that fibroblast tissues, it produces collagen fiber as well as the elastin protein. The same thing is happening here also. If there is a tendon injury, these fibroblast cells will come to the site of that tendon injury, and it produces enormous amount of collagen fiber, which fills the gap of this injury. Now, the next stage is the remodeling stage, that is in between 6 weeks to 12 to 14 weeks, and it decreases cellularity as well as a decreased collagen fiber. Now, the another important thing is the tendon healing. It is also important to know this tendon healing. There are two types of tendon healing: intrinsic healing and extrinsic healing. Now, it's up to you whether you are going to encourage the intrinsic healing or you are going to encourage the extrinsic healing. If you encourage the intrinsic healing, that means the adhesions formation will be less. So it will give you the optimum result. But if you are encouraging extrinsic healing by the reason of any, then it can cause formation of more adhesions, which will minimize the gliding of tendon, and probably you will have the poor prognosis. Here I will give you the example. You can see here in this picture, in a stage of inflammation, the phagocyte cells are present. This is the bridge where the tendon is cut, and there is a gap here. Now, if you come to after the repair, if you see this tendon, there can be two options. Either you are going to immobilize the tendon or you are going to mobilize the tendon. Now, if you are going to immobilize the tendon, there will be two types of healing. One is extrinsic healing. Now, this portion you can see in the tunnel. This is a tunnel where the tendon is present. And in the tunnel, you can see the outside, some adhesions are formed, some collagen fibers are accumulated. This is because you have immobilized the tendon, and it has encouraged the extrinsic healing. Due to that, there is a adhesion formation here, including the, if you compare with here, when the tendon is mobilized, there is a intrinsic healing, and there is no adhesion formation in between the tunnel and the tendon. So if you are, so it shows that if you are following early mobilization protocol after tendon repair, then that will give you the optimum result. Now, in the remodeling stage, you can see there is a adhesion formation which will minimize the gliding of tendon. But here, if you are following the mobilization protocol, there is no adhesion formation in between the tendon and the wall of this tunnel. So here the tendon can glide easily and it can give you the optimum result. I hope it is audible to everyone. Can I get a feedback from you?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Thank you very much.
Yes, sir. Yes, sir.
Okay, now let us, as I told that if you go for encouraging intrinsic tendon healing, so there will be lack of adhesion, there will be good tendon gliding and good range of motion. Whereas if you are encouraging extrinsic tendon healing, there will be presence of adhesion, poor tendon gliding, and poor range of motion. Now coming to the flexor tendon zone, which is important as a therapist to know. It is given by Vardhan. It is also called the Vardhan zones. There are 5 zones. If you can see here, there are 5 zones. Zone 1, if you can see, is the distal phalanx as well as the DIP joint. Zone 2 is the proximal phalanx, MCP joint, and if you see the zone 3 is the metacarpal area. Zone 4 is the carpal tunnel area, and zone 5 is proximal to the carpal tunnel. The same here, although we are not going to discuss about the thumb, but there are 5 zones in the thumb also: T1, T2, T3, T4, and T5. Now here we can see the contents based on the zone. You can see here in zone 1, there are 3 pulleys present: A4, C3, and A5. It is important for us to understand this because when the patient is referred to you, it will be referred as that the patient having zone 2 injury or zone 1 injury. So you must understand what are the components involved in that zone. It will help you to prepare the protocol post-operatively. So here you can see in zone 1, A4, A5 and C3 is present, whereas in zone 2, A1, A2, C1, A3 and C2 pulleys are present, along with the flexor digitorum superficialis and profundus tendon with the neurovascular bundles. So there are so many structures present in zone 2 area. That is why when there is an injury in zone 2, the prognosis is poor. That's why it is called the no man's land. But in present situation in 2020, we cannot say it as a no man's land because there are so many experienced surgeons as well as the experienced therapists. They probably have got optimum result even in there is an injury in zone 2. So now it is called some man's land. Now coming to the pre-operative test, although we are not going to do the pre-operative test, but it is interesting to know the pre-operative test when the patients are coming to the surgeons, how they do it. And they go for the individual flexor digitorum profundus test. They stabilize the finger and they ask the patient to go for the individual flexion of flexor, DIP, then individual flexor digitorum superficialis for individual flexion of PIP, and for both flexor digitorum superficialis and profundus, you can go for making hook fist. So in that there will be both. And then the other one is abnormal change in normal cascading. When you ask the patient to do some movement with the finger, you will see some abnormal activity movement in the finger which is affected. Maybe if the patient is trying to grasp something, you will see that the affected finger is not participating in that grasp. Now the another one is very interesting is the squeezing the forearm musculature. You can try right now also if you sorry. If you go for squeezing the forearm like this, you will see your tendon is moving. I mean, you are able to flex the finger. So that means the tendon is intact. So if the tendon is not intact, suppose my index finger having some tendon rupture. So if I'm doing this, the index finger probably will not be able to flex. So this is what one taste pre-operatively. Then another one is the tenodesis action. You can go for the wrist flexion. During that, there will be extension of PIP, DIP, and MCP joint. When you go for the extension of wrist, there will be flexion of MCP, PIP, and DIP joint. Now, this is very interesting to see if the finger is flexed and during that time, if the injury is happening. That is the reason when the patient comes to us, we go for the history of injury. Now, if you ask the history of injury, if the patient has flexed finger during injury, the laceration site of his skin and the laceration site of the tendon may not coincide, because when the finger is in flexed position, the tendon will pull proximally, so it will not coincide. So that is why when the patient is coming to the surgeon, the first question surgeon asks that how it happened, to find whether the tendon and the skin laceration are at the same point or it is proximal or distal to the site of a skin injury. Whereas if it is in extended position, the skin and tendon lacerations will coincide. I hope you understand all this.
Yes, sir.
Yes, sir.
Can I get a feedback?
Yes,
Am I
sir.
audible or no?
Yes, sir.
Okay,
Audible.
thank
Audible.
you. Thank you very much.
Audible, sir. Thank you, sir.
Then coming to the surgical management, as I told you in the beginning that although we are not going to do anything more in that, but it is important for us to understand, because without knowing that, it will be difficult to prepare the patient-oriented protocol, because there are different types of surgery, different types of suture, different types of even incision. So based on all these backgrounds, probably we prepare the client-oriented protocol. That is what I do in my clinical practice. Now here, the first surgery, which is the commonest, is the tendon repair. There are different types of tendon repair. I'm not going in all those details, but there are two types of skin incision also. Brunner incision, you can see here it's a zigzag incision. It's a zigzag incision where you can get excellent exposure, and this is the preferred approach, uh, which will, but the problem is it increases the scarring because it is on the palmar side. So when you give the patient with such type of incision, you'll have to be very careful from the beginning that the scar should not mature. Now there is another method of incision is mid-lateral. You can see here the mid-lateral incision. Now this is the advantage is to decrease scarring over the flexor surface because it is at the lateral side. It is not on the palmar side. So this will give you advantage. So probably it is more technically more demanding, and but the problem is in this incision, the branches of digital nerves and the vessels gets damaged. Now coming to the suture, there are two types of suture. One is core suture. Here you can see the 4-strand core suture, which is the commonest nowadays. And there is another suture that is called circumferential epitendinous suture. Here you can see the epitendinous sutures. There are certain surgery, there are some surgeons who does both circumferential epitendinous suture as well as this core suture. Now, if you talk about the based on the strands of suture, there are 2-strand suture, there are 4-strand suture with different name, and there are 6-strand suture. Even there are 8-strand suture. Most of the Chinese surgeons they do 8-strand suture. Uh, Now, based on the strands, you can understand whether the suture is strong or weak. Now, if the patient is coming to you with a 2-strand suture, that means you should have precaution because there is a chance of rupture of this suture, damage of this suture. But if the patient is coming with the 4-strand, 6-strand, or 8-strand suture, it is it is going to give you benefit in the sense you will be able to start as early as possible the active range of motion exercise. But there are some complication also that we will talk later, that which suture is probably better for rehabilitation. Now here 2-strand suture, then you can see here 4-strand suture, then 6-strand suture. Now, what is the significance of different types of suture? Now, if there is a 2-strand suture, it's a weak suture, there will be more gap. For example, suppose this is the tendon, and if the surgeon is going for 2-strand suture, so when the patient is going to contract the muscle and glide the tendon, there is a chance of more gap here because the suture is only 2-strand. But whereas if the surgeon is going for 4-strand or 8-strand suture, then when the patient is trying to pull the tendon, the chances of gap is very less. So that probably can give you better outcome. Now, this is another concept to understand that, as I told in the beginning, that some surgeons, they prefer to go for both epitendinous suture as well as the core suture. So here it is done both epitendinous and core suture. So in that situation, there is a chance of encroachment inside the tunnel of this tendon, because it is going to be more inside the tunnel. So it is going to affect your gliding. It is going to create more adhesions, and probably it can lead to contraction and deformity also in late stage. So if such type of patients are coming to you, you have to be more cautious since beginning that how to implement active range of motion exercises as early as possible. That is the reason I'm talking about all this surgery. Because if you don't know that what type of surgery is being done with that specific patient, you will not be able to get the optimum result. Now, this is external and internal knots. When the surgery is being done, these two types of knots are done. If there is internal knots, probably you'll get better result because the knots are inside and it will not encroach that tunnel, and the tendon will get proper gliding. There will be less adhesion and there will be optimum result. So you will like if the patient is coming with internal knots, but if surgeon has preferred to go for external knot, so you'll have to be cautious since beginning that probably there will be some sort of encroachment inside that tunnel, which may affect the gliding as well as it will encourage the adhesion formation inside the tunnel. Now, this is the second type of surgery, tendon graft. If the first surgery is not been successful, then the second tendon graft surgery usually is been done. And in some cases, if the injury is in zone 2, where the what is called so many structures are involved, so in that situation, tendon graft is the option. And the third type of surgery, which I'm not going in detail, is stenolysis. If both tendon repair and tendon graft is failed, then or after even your therapy, if you did not get the optimum result, then the surgeon has the only option to go for stenolysis. Now coming to the post-operative management of flexor tendon injury. Now, as I told in the beginning that there are 9 tendons which we usually discuss in the flexor tendon injury: 4 flexor digitorum superficialis, 4 flexor digitorum profundus, and 1 flexor pollicis longus. But if the injury happened at zone 5, then flexor carpi radialis and flexor carpi ulnaris you cannot ignore. So these are the tendons we are going to talk about in our post-operative management. Now coming to the post-operative assessment, we also call it the pre-splinting evaluation, because the patient will come with the posterior slab, and then your first aim is to go for a basic small evaluation, and then you will start fabricating a splint according to the patient condition. Now here in pre-splinting evaluation, we talk about the history. As I told in the beginning that the history of injury and all is very important. Even the history, like whether the patient is diabetic, whether the patient is alcoholic, whether the patient taking cigarette, these all things are very, very important, because if the patient taking cigarette, probably the healing is slow. So in that condition, if you are trying to go for active protocol, you'll have to be a little bit cautious. If the patient is alcoholic, probably if you are going for active range of motion exercises, or if you are giving some instruction to that patient, probably he may not follow because he is drunkard. So that is the reason history is also very important. Then hand dominance as usual, occupation, and passive range of motion, you need to check. But you are not going to bring the hand outside the plaster cast. You are not supposed to bring the hand outside the plaster cast. You are going to check the passive range inside the cast, which is required during your protocol. Okay, then you will be going for sensation, then edema. Edema is very important. If there is a moderate to severe edema, when the patient is coming to you, probably you cannot go for making a splint, because if you go for making a splint when there is a moderate edema, it will give more load on the suture when the patient is going for any active contraction of the muscle. So that is why when the edema subsides, then we go for the fabrication of a splint, and we apply our protocol. Then condition of nail is very important, the nail bed especially, that I will show you why it is very important. Then wound, if there is oozing of wound, probably you should inform the nurses as well as the surgeons. Then the different types of suture, as I discussed, you should know. Then the surgery also you should know. Now coming to the protocol, what we are following after tendon injury, there are three types of protocol. One is immobilization protocol, early passive mobilization, and early active mobilization. Now let's see what it is. Now immobilization protocol, it is applied when the patient is child or younger than 10 years, because the patient probably may not follow what you will explain to follow. And then the other one is if your patient having some cognitive deficit, probably that also is not fit for any active mobilization protocol. So then if so many structures are involved together, for example, if the vessels are involved, if the fracture is involved, in case of cross injury. So in that condition also, usually the surgeons prefer to go for immobilization approach. And another one, as I told, when the patient ignores precautions, if the patient is casual, that patient probably may not follow what you are going to instruct. So in that condition, it's better to go for immobilization approach. Now, immobilization protocol, which is developed by Cifali, Collins, and Saurge, and there are three stages. In 0 to 3 or 4 weeks, they used to go for the dorsal blocking splint, where the wrist is going to be 20 to 30 degree of flexion, MP joint 40 to 60 degree of flexion, and full extension. That is what will be the dorsal blocking splint, and the patient can use it for 24 hours except therapy time. Now, what are the exercises you are going to follow in this early stages is range of motion of uninvolved joints, gentle protected passive range of motion exercises, and protected intrinsic stretch exercises of in the wrist flexed position. You have to keep the wrist in flexed position and intrinsic stretch exercises for the fingers. Then also you can go for a scar massage. Usually the scar massage is done after suture is removed, and the time for the removal of suture is in between 10 to 14 days. Now coming to the intermediate stage that starts at 3 to 4 weeks. The patient will continue the dorsal blocking splint, but there will be some modification in that splint. The wrist will come in neutral, and MP joint and IP joint will be in the same position. Then remove splint hourly for the exercise by the patient. Then exercises 10 degree of extension, with wrist 10 degree of extension and 10 repetitions of passive digital flexion and extension. Then 10 repetitions of active differential glide and tenodesis exercise. These two exercises are very important, this active differential glide and tenodesis exercise. Now I will show you here. This is the active differential glide of both flexor digitorum superficialis and profundus. Now this is the position where both flexor digitorum superficialis and profundus both are gliding on each other. That is very important to do it to minimize adhesions. Then another one is the tenodesis exercises. As I told, the wrist will be in flexed position. During that time, the MCP and IP will be extended. And when you go for the wrist in extension, both the MCP, PIP, and DIP will be flexed. This is a very good exercise for gliding of tendon. Now, the important thing which you have to follow as a therapist is after 3 to 4 weeks, it's not days, of these exercises, when the patient is coming to you, then you have to go for a small evaluation. You have to go for measurement of total active motion, that is TAM, and total passive motion. Now, if there is a discrepancy between the total active motion and total passive motion more than 50 degrees, then you have to go for the next phase of therapy. Now you should understand why we have to go for next phase of therapy. If the total passive motion is better than the total active motion, and if the difference is more than 50 degree, that means the adhesions are formed in the tunnel. And now, if the adhesions are formed in the tunnel, if the patient is going for any active contraction of muscle, it is not going to give any load over the suture. I hope you are able to understand this. So in that situation, even if you are going for next phase of therapy, it is not going to affect, it is not going to create any problem related to the suture. Now, but if the discrepancy is less than 50 degree, you can continue the same until the 6 weeks of repair. Now, why we should continue until the 6 week of repair? Because the adhesions are not formed and the tendon is free to glide. Now, if the tendon is free to glide and you are going for some sort of very active exercises, there is a chance of rupture of that tendon again. So that is the reason, if the movements are good, then you should continue till 6 weeks of repair.
Sorry, sir. Sir, one more student have joined. Can you accept the request, sir?
Okay, let me see who is.
See, sir.
One person is waiting. Okay. Admit. Is it done? Is it done?
No, sir. No, sir. Okay, sir. No, it's done, sir. Okay, thank you, sir. You continue, sir.
Okay.
Yes, it's done, sir. It's done. Now the participants are done. Okay, continue, sir. Thank you, sir. Thank you, sir.
Okay, so now in late stage, which starts at 4 to 6 weeks, the dorsal blocking splint will discontinue. Now here is the important of, as I told in the beginning, the inflammatory stage, the remodeling stage, the modeling stage, all these stages. Now in late stage, the adhesions are already formed. It is almost healed. The gap is been filled by the collagen fiber. So you can discontinue this dorsal blocking splint and you can go for Palmer Knight splint to minimize, because most of the time if the hand is going to keep it in the wrist flexion, MCP flexion, there is a chance of contracture at the wrist, MCP joint, as well as sometimes the PIP and DIP also. So this is the splint we use to stretch it in the night. Whereas in the daytime, the patient is allowed to do some active exercises as well as some day-to-day activities, light day-to-day activities. Now, progressive splint can be used and the serial casting can be done. Serial casting, I do serial casting, although it is not very famous in Dubai to do this serial casting, but I learned in my college, Nirtar, this serial casting. I have found here with some patients very effective. If the scar is formed too much and there is a contracture in PIP joint, this serial casting works very good. Now coming to the late stage exercises, blocking exercises, isolated FDS and FDP, you can block the movement of flexor digitorum superficialis and go for individual flexor digitorum profundus. You can block this movement and you can go for individual flexor digitorum superficialis. This you can do 10 repetitions 6 times a day. Then the previous exercises will be continued. You can recommend the patient to go for light pickups activities, and at the time of 8 weeks you can go for light resistance exercises with the grip, and in between the 10 to 12 weeks the patient can return to the job. Now there are certain modalities because it's a immobilization protocol, so usually in immobilization protocol the prognosis is not very good. So in that situation, in late stage, there are some scope of using these heating modalities as well as electrical stimulator, deep friction massages, and the dynamic splint. You can see here the dynamic splint which is made by us in our department. Now coming to the early passive mobilization protocol. This is very famous protocol which probably been used in throughout the world. One of them is Cleanard protocol, probably you must have heard, and the Duran and Hauser protocol. Now, early passive mobilization protocol, Duran and Hauser, in between 0 to 4.5 weeks. Again, the dorsal protective splint, but here the Duran and Hauser has done some sort of changes in the wrist flexion, MCP flexion, and the IP joint full extension is common in all the protocols. Then these are certain exercises. I am not going all in detail because I am not using Duran and Hauser protocol in my clinical practice. My favorite one is not even my, everyone favorite is to go for the Cleanard protocol. So I will talk more about the Cleanard protocol. Cleanard protocol. Here you can see the dorsal blocking splint where the wrist is at 45 degree of flexion, MP 10 to 20 degree of flexion, and in modified Cleanard, now we are using modified Cleanard. In that, the MP joint is 40 degree of flexion. You can see here very important structure, that is a rubber band applied. Now this rubber band, through that the patient can go for active extension inside the dorsal blocking splint, and the rubber band will pull the finger passively uh, uh, in the flexor. This is what the changes in the early passive mobilization protocol. So you are going to apply. Now, as I told in the assessment, that we need to know, we need to check the nail of the patient. Here it is not visible, but I will show you my own splint in the later stage of this presentation, that there are some hooks here applied in the nail, which is going to pull the finger in flexor. Now in Cleanard protocol, the exercises every hour inside the splint 10 times, allowing the rubber band to flex the finger. The same exercise, nothing else you are going to do. The rubber band is going to pull, and you are going to actively extend the finger inside the dorsal blocking splint. In intermediate stage, gentle active exercises, and in late stage, resisted exercises has been done. We will discuss the preferred approach, what I am following in my department. That's why I'm not going that also in detail, because I'm not using the actual Cleanard approach. I'm using my own preferred approach, although it is based on Cleanard. Now there are certain complications of Duran, Hauser, and Cleanard. You can see here, if you are using going for Duran Hauser, there is a band here in the wrist which is going to pull the PIP, which is going to flex the finger, and here there is a flexion of PIP joint. But if you are going to continue it for a long time, then there is a chance of PIP flexion contracture. So what is the change you are going to do in your splint to minimize this problem? So you are going to not the flex, you are going to extend the finger in the night time through this night splint, rather than going for full-time finger flexion. Now, difficulty in extending the injured finger fully against excessive resistance of rubber band. It happens when the finger is flexed and you are going passively to extend the finger. If the rubber band resistance is more, probably your patient may not be able to extend it till till it is allowed in the splint. So in that, maybe it will be like this. So in that situation, you need to change the rubber band with a different resistance, or you can go for the single strand of that rubber band. The another modification in cleaner is here. If you see, this rubber band is going to bend only PIP joint, not DIP joint. So that means the differential glide of flexor digitorum superficialis and profundus is not going to happen, which is very, very important to minimize the adhesion. If you have the differential glide of both the tendon, the outcome will be excellent. If you don't have, there will be some compromise. So to minimize this problem, there is another inclusion inside it is called the Palmer pulley. Now here you can say this is made by me. The Palmer pulley is applied, which is going to flex the DIP joint also with the PIP joint. So it is going to redirect the force through this Palmer pulley, and in that way you are going to glide both flexor digitorum superficialis and profundus. That is called the differential gliding of FDS and FDP. It also helps in minimizing the stiffness at DIP joint. If you go for this, the DIP probably will be stiff. If you go for this, the DIP will not be stiff, and there will be lack of this adhesion formation. Now coming to the other one, as I told, sometimes the patient probably may not be able to extend it fully because of the stiff, what is called the rubber band. So in that situation, you may go for using the nylon fishing thread. We use it in our department, the nylon fishing thread. When the patient goes till here, the last 10 to 20 degree is very easy to go for extension with the help of this nylon fishing thread. Then the another concept is the four finger, whether you are going to use this these hooks in both all the fingers or only in the affected fingers. Now, if you are going to use, suppose the index finger is affected, so you can go for index finger like this. But when you are going for passive flexion of index finger, it is sometimes not comfortable. Even if you can try in this stage, you can try when you are going for passive flexion of one finger, it is difficult to do it. Rather than you are going for all finger, it is easy. So that is why some therapists, they use all the fingers, even if there is one finger affected. Yes. Shall I continue?
Yes, sir. You can continue, sir.
Okay.
Last
Now,
the discussion will be last, sir.
okay.
Okay, sir.
Now, as I told that I am not following. Suppose if one finger is affected, I never go for all the fingers with this traction and the movement. I go for that specific one. The reason behind it is, if you go for only one finger to be in flexed position and exercising this, there is more chance that these three fingers is going to have some sort of involuntary contraction movement, because in day-to-day activity, sometimes if this is involved with the rubber band, but these three are free, so these three can move anytime. But this movement, this cheating, in fact this is a cheating, but this cheating sometimes is beneficial. So that's why when there is one finger affected, I go for only one finger traction with this rubber band, and these three fingers used to be free. Now coming to the early active mobilization protocol. Now this early active mobilization protocol is used when there is severe edema. It is not common still in India using this early active mobilization protocol, because most of the friends I speak to, they say that still the surgeon doesn't have much confidence to go for this early active mobilization protocol. We will not go in detail about this early active mobilization protocol. Here, one thing I would like to add: what is the difference between early active mobilization and early passive mobilization? There are certain differences. Try to hear it properly. When you go for early active mobilization, that means your muscle is being contracted and then the tendon is gliding. So that means your tendon is being pulled proximally when you are going for early active mobilization. When you are going for early passive mobilization, you are pushing the tendon proximally. Not tendons are not pulled. In fact, you are pushing the tendon proximally. So that concept you have to keep it in mind, that when you use early passive mobilization, whenever you get chance to have some active movement, if you have confidence, when you have some chance to use active movement, try to use active movement also along with this, because that active movement will glide the tendon genuinely. This passive movement will not glide the tendon genuinely. There are different types of early active mobilization protocol that we are not going to discuss in detail. Then we will come to I will be going to present a case that probably will be better for you to understand what needs to be done, as I came to know that all are postgraduate students. Probably some of them or most of them will be practicing this. So we will discuss about this case. It was a 40 years old Indian male working in a glass company, and he had a glass cut injury diagnosed as flexor digitorum profundus cut in middle ring and little finger of left hand, and the surgery was performed as tendon repair. The patient came with the plaster cast. Now this is the patient came to us with the plaster cast. Then as usual, we go for this pre-splinting evaluation, which I discussed before. And then I preferred to go for early passive mobilization protocol that is based on clean air protocol with some inclusion and exclusion. That's why I used to tell it preferred protocol. So in between 0 to 3 weeks, the dorsal blocking splint is being made, where I used to keep the wrist in 20 to 30 degree of flexion, and MP joint 50 to 70 degree of flexion. IP joint will be in full extension. Now I will try to tell you one thing, as Dr. Sarad also told me, to talk something that what not need to be done by the therapist to minimize the chance of any injury. So what exactly you should not do, that I will try to emphasize here. If you deal with the flexor tendon injury, it's very simple that don't go for any extension. Simple thing, don't go for any extension, neither at wrist nor at MCP. Of course, the IP joint will be extended. If you are going to mobilize in later stage, this flexor tendon injury cases, don't mobilize all the joints together. The adjacent joints should be in rest or in flexed position. If you are following these two concepts, probably the chances of mistakes are very, very less. I will give you the example. For example, you kept the patient in dorsal blocking splint for 2 weeks, and then after that you are trying to go for some exercises. If you want to go for MCP flexion and extension, don't allow the wrist in extension. Or if you are going for PIP joint flexion and extension, don't allow the MCP in extension. So if you are going for PIP flexion extension, keep the MCP joint in flexion to be safer side, and then go for PIP flexion and extension. Don't do all the joints together. So that is the safe way to handle the tendon injury, especially the flexor tendon injury case. Okay, now coming to this is the patient. The splint is fabricated after first dressing. Why the first dressing is important? You may get patients with severe edema, moderate edema. In that situation, if you are going for this dynamic splint, I mean this cleaner splint, it is difficult to get proper gliding of the tendon. And if you are trying to glide the tendon there is a chance of extra strain over the suture. So always get the patient when the edema has subsided or near to subside. If you are getting it, return it back, or tell the doctor, tell the nurses that the patient is not fit at present for any such type of splint. Then this is the position. This one thing I would like to add to be in safer side. Whenever the patient is coming to you, if you are opening the splint, removing the splint, or removing the plaster cast, always keep in this position. This is the most safest position for any flexor tendon injury cases. So before preparing the splint, we used to keep it in this position. Then this is the thermoplastic we use. Now here is the oven, and if you see the second picture, the transparent, this thermoplastic. Once it becomes transparent, that means it is ready to make the splint. It is applied over the dorsum of hand and forearm, and here you can see in both the sides the margins are curved so that the fingers will not come out from the splint. It gives the stability, and here there is a extension which will help in stabilizing the finger. Then the splint is done. Now, as I told, we use this hook uh, for applying this rubber band, and that is the reason the nail bed should be healthy. If the nail bed is affected, you cannot go for this. Now, in the older time, in place of this hook, the surgeons used to go for piercing the nail and applying the rubber band. But now it is changed. Now the splint is ready here, you can see. Now here one thing I would like to add, as we know that our hand has dual obligated. Now if you see your hand, just see your hand, your index finger is facing towards the scaphoid bone, and the little finger is facing more towards the scaphoid bone. So when you are going for any sort of traction by this rubber band, you have to take care of this. You cannot go together all the rubber band together. You have to take care of the direction of this finger. Otherwise, unnecessary, it will create some strain over the tendon as well as ligament. Now this splint is done, and the finger is flexed passively with this. Here you can see it is very important when you are giving this splint. Now the hooks are inside the splint. Now because of this hook, there is always chance that the patient probably may not go for full extension at PIP and DIP, and that can lead to the PIP and DIP contracture. I hope you are understanding this. Yeah. So what is the solution? The solution is either you are going to keep this outside the splint, but this is again very dangerous. If your patient is literate, understanding, then you can go for this. Otherwise, the best solution is to apply a pad over the what is called the proximal phalanx and the middle phalanx area, so that this will create some gap here. So whenever the patient is going for extension inside the splint, there will be certain gap, and the patient will not have difficulty in extending both PIP and DIP. And that is in that situation, there is no chance of PIP and DIP flexion contracture. This is what the splint is all about. As I told, I usually keep the unaffected finger free. Now, unaffected finger free means that finger probably will cheat, will go for some sort of flexion movement. But that small flexion movement is going to give you benefit rather than going to give any difficulty. This is the important structure which we are going to add it, because in the night you are not going to keep this traction. you are going to keep it free. You are going to tie it so that to minimize the flexion contracture at PIP and DF. Now, one more thing which we used to say to the patient, that these markings, these arrow markings, we put it on the splint so that the patient will open this splint during the dressing only from one side, not from both the sides. If the patient is doing it from both the sides, the alignment of this rubber band will change. And as I discussed, that the God has given the dual ability of our hand, certain direction it is going towards this scaphoid bone, so that all these things will be changed. Now it is done. And there are certain exercises, as I told, 10 to 15 repetitions is been done inside this dorsal blocking splint. Okay. And we go for edema management and scar mobilization in between 10 to after 10 to 14 days, and place and hold exercises is being done at the time of 3 weeks by keeping the wrist in 30 degrees of extension. Place and hold exercises, you will go for certain amount of flexion and you will stay the patient to hold it in that position. Then at the 4th week, wrist is positioned in the neutral and active range of motion will be initiated. At the 5th week, this dorsal blocking splint may be discontinued. At the 6th week, then the dorsal blocking splint will certainly discontinue, and differential tendon glide exercises, as I told, this differential tendon gliding exercise for FDS and FDP will continue, and active range of motion exercises will be permitted. Light functional exercises activities also will be introduced. 7th week, you can go for stretching exercises, or you can apply the dynamic splint. And in between 8 to 12 weeks, there will be strengthening exercises, and the patient will return to work and educate. Now there is a video. If you want, I can show you that how this splint works. And post-operatively, we also teach the patient how to do the exercise. We also give some brochure to the patient related to the instruction and exercise. And then we call it, usually in the protocol it is mentioned 3 to 4 years, but I prefer to call my patient every week because most of our patients here are laborers and they don't understand this complication of this splint. So sometimes it gets deranged. So that is the reason I used to call my patient every week for follow-up. And these are certain splint which we use in post-operative complications. If there is a flexion contracture at PIP, then such type of splint is being used. This 3-point pressure splints. This is also finger knuckle bender splint, which we use in our department. These are my references. This is my surgeon, Dr. Mihai from Sweden.